Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! Welcome back. This episode is our third episode on antineoplastic agents and chemotherapies. Today we're going to be discussing PARP inhibition, Bevacizumab, and a few cytotoxic agents used in ovarian cancer that aren't typically used in uterine cancer. As in our other chemotherapy lectures, we don't have specific objectives and takeaways for this lecture, but you can find our show notes and some practice questions on our website, readysetgyo.com. Maya, let's start off one of the topics that's the most confusing to me: PARP inhibitors and their role in the treatment of gynecologic cancers. Can you tell us how PARP inhibitors even work?
Absolutely. And remember that in our ovary lectures, we also talked about the current FDA recommendations and approvals for all of these drugs. PARP stands for poly-ADP ribose polymerase. These are enzymes which live in the cellular nucleus. A simplified explanation of their job is that they identify single-stranded DNA breaks in the DNA helix after damage occurs, and they then recruit DNA repair proteins to come repair the strand breakage and restore the function of the DNA, helping the cell to survive. If PARP is unable to do this job, the single-strand break does not get repaired and eventually turns into a double-strand break. In a normal cell, the double-strand break should be able to be repaired via double-strand break repair mechanisms. The most reliable way that the cell has to do this is with homologous recombination. And a less consistent or more error-prone method to repair double-strand breaks is via non-homologous end joining.
By inhibiting PARP and thus the repair of single-strand breaks, PARP inhibitors force the cell to rely on double-strand break repair. If a cell is deficient in these homologous repair proteins, it means that they then don't have either of these mechanisms to repair the cell and are more reliant on error-prone non-homologous end joining, and therefore are susceptible to cell death.
So even though we think of PARP inhibitor as most useful in the setting of cells with homologous recombination deficiency and inability to repair double-strand breaks, where they act is slightly before this process would normally occur, at the time of single-strand breakage. There's evidence that PARP also works to aid in the repair of double-stranded DNA breaks. There are a lot of ways to define homologous repair status, and different definitions were used in the inclusion criteria for the trials on PARP inhibitors. Most commonly, we see germline or somatic BRCA deficiency, which leads to HRD, homologous repair deficiency, HRD, or loss of heterozygosity, LOH. HRD leads to genomic instability, which then leads to LOH with loss of potentially large portions of the genome, resulting in genomic scarring. BRCA1 and BRCA2 play prominent roles in the homologous recombination repair pathway and are the most studied contributory proteins. Aside from BRCA, other genes associated with an HRD phenotype include genes such as RAD51, POLB2, and ATM. There are other genes associated with HRD and some genes that we aren't sure about their association. When we talk about HRD, ideally we should be describing an actual current problem with DNA repair. Unfortunately, we don't have a way to actually measure whether cells are currently deficient in homologous recombination, so we have to use other markers as a proxy. These other markers are more historical markers of HRD, telling us that the cells at some point had HRD, either now or previously. Loss of heterozygosity, for example, is a genomic signature, also referred to as a genetic scar, that's thought to result from error-prone DNA repair through alternative pathways like non-homologous end joining. Thinking about it as a scar is important because the cells can restore their homologous recombination. If cells previously had HRD but have since restored their HR, they'll still show up as LOH high or still show up with a high GIS score because those scars on the DNA don't go away. The most common pathway that cancers develop resistance to PARP inhibitor and chemotherapy is through restoration of homologous recombination repair. So cancers may have genomic scarring because they previously had HRD. Reversion mutations are a common way to restore function of BRCA. Another important thing to note is that the meaning of LOH depends on the disease site. In endometrial cancer, LOH doesn't actually represent HRD. Rather, it correlates with p53 mutations. In disease sites other than ovary, LOH testing doesn't necessarily predict response to PARP inhibitor. Similarly, in clear cell cancer of the ovary, LOH doesn't accurately represent HRD. Sydney, can you tell us about the diagnostic tests?
Sure. Diagnostic tests come from companies that often have patented formulations. We're going to talk about a few more commonly used tests and describe what goes into them. Myriad has a My Choice test. They use a combination of results to determine a genomic instability score, GIS. This is a proxy measure for HRD. The GIS incorporates loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions, or large breaks in the chromosome. Foundation 1 assesses LOH and presents a score, with scores greater than or equal to 16% labeled as LOH high. Foundation 1 CDX and the Myriad My Choice CDX tests assess chromosomal instability using tumor tissue, meaning these incorporate both the causes, gene mutations, as well as the consequences, genomic instability like LOH. Conversely, BRCA analysis CDX and Foundation 1 liquid CDX use only blood to evaluate for HR mutations. Going forward in clinical trials, it's important to improve clarity regarding how HRD is defined, measured, and reported. Maya, so how does this apply in ovarian cancer, and what are the current FDA approval and recommendations for using PARP inhibitors in ovarian cancers?
Great question. This is pretty tricky. We did review this in our advanced and recurrent ovarian cancer episodes, so listeners can head there for a detailed discussion. Remember that about 15% of patients with high-grade serous ovarian cancer have a germline BRCA mutation. About 25% then have a somatic BRCA mutation, and so up to 50% of all ovarian cancer patients will have HRD of some type. That means a lot of people have potential benefit from PARP inhibitor. Currently, in the upfront setting, PARP inhibitors have FDA approval for use as maintenance, with each drug having different indications based on HRD status. Remember, the existing trials on PARP inhibitor consistently show us that they work the best in patients with BRCA mutations, next best in those with some other form of HRD, and have the least benefit in HR proficient tumors. In the recurrent setting, PARP are only approved and only have shown benefit in platinum-sensitive patients as second-line or greater maintenance for patients with BRCA mutation. Again, the specific FDA approvals were discussed in our ovarian cancer episodes. Sydney, one of the nice things for patients about PARP inhibitors is that they're administered orally, so people can take them at home and don't need to travel to clinic for infusions. What are some of the potential downsides and toxicities from PARP inhibition?
These medications overall are relatively well tolerated. As with many other chemotherapies, they do tend to cause nausea and vomiting, with up to 75% of patients experiencing nausea. We should give all patients receiving PARP inhibitor treatment antiemetics and reassurance that for most people, the nausea tends to improve over time. A PPI for dyspepsia can be used if the patient is experiencing symptoms. PARP inhibitors also cause fatigue in most patients. While this is a common side effect, it's important to rule out other modifiable causes of fatigue like anemia, hypothyroidism, and nutritional imbalances. Insomnia can be a common complaint as well, so sleep hygiene and management become important to help manage fatigue. Nephrotoxicity with an elevated creatinine can be seen with rucaparib and olaparib, but tend to stabilize and downtrend over time. The most concerning side effects of PARP inhibitors are hematologic, both short-term and long-term. In the short term, myelosuppression can occur, with RBCs being the most likely cell line to experience suppression. Up to 38% of patients will experience greater than or equal to grade 3 anemia. Anemia can be managed with dose interruption or reduction and transfusion if symptomatic. Thrombocytopenia can also occur, with up to 34% of people experiencing greater than or equal to grade 3 reactions. Niraparib specifically has the highest rate of grade 3 thrombocytopenia. Patients on niraparib need to be followed with weekly CBCs for the first month and then monthly thereafter. Again, dose reductions or halting the drug are sometimes necessary. If stopping, it's important to do weekly CBCs until recovery and refer to hematology if blood counts aren't improving within 4 weeks. Long term, patients can develop myelodysplastic syndrome or AML. The risk of these conditions is between 0.5 to 1.5% and increases with duration of exposure. In the SOLO-2 trial, 8% of patients developed one of these conditions compared to 4% in the placebo group. Remember, the starting dose of niraparib is based off patients' platelets and weight, as these two factors have been associated with an increased risk of myelosuppression. So, if the patient's weight is less than 77 kilos or platelets are less than 150,000, start at 200 milligrams daily, not 300 milligrams daily. Maya, how should we choose between the different PARP inhibitors if we're planning to treat our patients with one?
There are a few things to consider. First, it's important to review the FDA recommendations and confirm that your patient has a germline or somatic BRCA mutation, whether they have HRD, genomic instability, or none of the above, as this will dictate which agents you can use as an option. Olaparib is the PARP inhibitor with which physicians may have the most familiarity, but it also has drug interactions associated with it, and it requires twice daily dosing. Niraparib is the only PARP inhibitor that's dosed once daily, and nighttime dosing can help mitigate nausea. It's also the only PARP shown to cross the blood-brain barrier, so it can be considered in patients with brain metastases. Rucaparib has more dosing flexibility in milligrams and doesn't have the same CYP3A interactions as other PARP inhibitors, so it may work better depending on people's other medications. Sometimes insurance approvals also impact which agent will be financially feasible for our patients. We usually base our decisions off of patient-specific effects on chemotherapy, so steering them more towards niraparib if there have been a lot of GI issues, or more towards olaparib if there's considerable myelosuppression on platinum-based chemotherapy. Rucaparib can be great for loss of heterozygosity patients given the data from the aerial trials, and if you want more dosing options for patients. Lastly, niraparib can be used in patients with HRP tumors in the frontline setting, but this is typically reserved for patients with residual disease who have contraindications or declined bevacizumab therapy. Speaking of, Sydney, can you review the indications for bevacizumab in ovarian cancer?
Bevacizumab has a role in all 5 gynecologic malignancies for use in either upfront or recurrent treatment. Recall that in ovarian cancer, bevacizumab is used in the upfront treatment of ovarian cancer, including for maintenance, in combination with chemotherapy, and is also approved for both platinum-sensitive and platinum-resistant ovarian cancer. We reviewed the Kellam score for bevacizumab in our Ovary Part 2 lecture. Reminder that this is a validated predictive score that can be employed to decide which patients will benefit from the addition of bevacizumab. It incorporates the rate of change of CA-125 during initial treatment with chemotherapy. Patients with an unfavorable Kellam score tend to derive the most benefit from bevacizumab. Maya, how does bevacizumab work, and what are the dosing considerations?
Bevacizumab is a monoclonal antibody against vascular endothelial growth factor A, or VEGF. It works to prevent angiogenesis in tumors. There are other anti-VEGF monoclonal antibodies, and per the NCCN guidelines, it is acceptable to substitute other FDA-approved biosimilars. There are also tyrosine kinase inhibitors like pazopanib that do target VEGF as well. Dosing for bevacizumab is weight-based. Typical dosing is either 15 milligrams per kilogram, which was used in a lot of the US GOG trials, or 7.5 milligrams per kilogram that was used in ICON 7. These can be dosed every 3 weeks, and another option is to do 10 milligrams per kilogram every 2 weeks. Because of the anti-angiogenic properties of bevacizumab, it has some unique toxicities. Sydney, can you walk us through some of these?
Sure. Bevacizumab can cause delayed wound healing, so it should be discontinued 28 days before surgery and also shouldn't be restarted until at least 28 days after surgery. Hypertension is a common side effect of bevacizumab, with 25% of patients experiencing greater than or equal to grade 2 hypertension, as compared to 7% of controls. This can typically be managed with antihypertensives, and pre-existing hypertension is not a contraindication. Expert opinion has recommended to start with a low-dose calcium channel blocker, such as amlodipine, but an ACE inhibitor or an ARB can be used if the patient is experiencing proteinuria. Proteinuria occurs in 13% of patients receiving Bev, but greater than or equal to grade 3 proteinuria only occurs in up to 2% of patients. It's important to do a urine protein dip before each dose. If patients have 2+ protein on UA, then a 24-hour urine collection or a protein to creatinine ratio is warranted. If patients develop nephrotic syndrome with greater than 3 grams of protein in 24 hours, bevacizumab should be discontinued indefinitely. Note that this syndrome will usually resolve with discontinuation. Maya, can you tell us about some of the more scary side effects that patients may experience with bevacizumab?
Of course. There's an increased risk of VTE with bevacizumab treatment, which can occur in around 8% of patients. Treatment involves therapeutic anticoagulation, and bevacizumab can be restarted after treatment is completed. A history of prior VTE isn't a contraindication to bevacizumab. Arterial thrombotic events are also more common with use of bevacizumab and occur in 2 to 3% of patients compared to less than 1% of controls. Examples include cerebrovascular accident or MI. Risk factors for ATE include age greater than 65 and a prior arterial event. If patients experience one of these events with bevacizumab, it needs to be permanently discontinued. There's an increased risk of bleeding, most commonly epistaxis, with less than a 1% chance of CNS-related hemorrhage. GI perforation and risk of fistula formation is a potentially life-threatening adverse effect associated with the use of Bev. While earlier studies suggested that rates of this were occurring around 10%, more recent studies like GOG 218, ICON 7, and Oceans have shown rates of GI perforation and fistulization to be around 1 to 3%. A history of inflammatory bowel disease and history of bowel resection during primary surgery are both risk factors for perforation. Given this rare but life-threatening risk, the presence of bowel involvement or signs of bowel obstruction are both contraindications to the use of bevacizumab. Finally, there's less than a 1% chance of patients experiencing reversible posterior leukoencephalopathy syndrome. This is typically preceded by uncontrolled hypertension and presents with headache, lethargy, confusion, seizure, or blindness. That wraps up our coverage of the targeted agents commonly used in ovarian cancer. Next, we want to cover a few cytotoxic agents that weren't covered in our uterine chemotherapy lecture.
Carboplatin and paclitaxel are also the backbone of ovarian cancer treatment. For more specific information on these agents, refer back to Episode 7, Uterine Cytotoxic Chemotherapy. Additional agents included in that episode which can be considered for the use in treatment of ovarian cancer include cisplatin, gemcitabine, ifosfamide, liposomal doxorubicin, albumin-bound paclitaxel, docetaxel, and topotecan. Today, we're going to spend our time discussing in detail the remaining cytotoxic agents which weren't covered in the uterine chemotherapy lecture. We'll structure our discussion similarly to the uterine cytotoxic episode by discussing each of the remaining ovarian cytotoxic therapies according to their cytotoxic therapy class. Maya, how about we start out with the antimetabolites?
So in our last chemo episode, we reviewed gemcitabine, which is an antimetabolite with indications in uterine cancer as well as in epithelial ovarian cancer. Capecitabine and pemetrexed are both antimetabolites that also have a role in the treatment of ovarian cancer. Capecitabine is used in mucinous ovarian cancer as part of the CAPOX regimen with capecitabine and oxaliplatin, and this is a regimen traditionally used in GI cancers. Capecitabine is an oral fluorouracil prodrug which gets converted to 5-FU in tumor tissue. Thus, it has the same mechanism of action as 5-FU. The exact mechanism of action isn't completely described, but these drugs are thought to inhibit thymidylate synthase, leading to less thymidine availability for DNA synthesis, as well as creating single-stranded DNA breaks. Capecitabine can cause severe watery diarrhea, which can be life-threatening. Other GI effects include stomatitis and mucositis. About 3 to 5% of the population can have a deficiency in how capecitabine and 5-FU are metabolized, resulting in quick and severe toxicity to therapy. We mention this as a caution. Watch for severe early toxicity, stop therapy, and get pharmacogenomic testing of DPD. Fun fact, there is a reversal agent if you catch this and administer it within 24 to 48 hours of administration of 5-FU. Patients can get hepatotoxicity with elevated LFTs and can experience myelosuppression 9 to 14 days after administration. Capecitabine requires renal dose adjustments, so be sure to ask your pharmacist for help when dosing those with renal dysfunction. Dermatologic effects include hand-foot syndrome, as well as photosensitivity hyperpigmentation. Urea cream can be helpful for prevention of PPE. Patients can also get a cerebellar syndrome with capecitabine, experiencing headache, ataxia, nystagmus, and confusion. While usually reversible, this can be permanent.
Another antimetabolite used in ovarian cancer is pemetrexed, which can be used as a single agent for recurrent ovarian or cervical cancer. This medication inhibits several enzymes with the end result of inhibiting purine and pyrimidine synthesis and is a derivative of folic acid. Toxicities include myelosuppression, rash, diarrhea, nausea, vomiting, anorexia, and fatigue. Folic acid and vitamin B12 supplementation should be given and started 1 week prior to initiation of therapy to reduce GI toxicity, and steroids may also be given to reduce the risk of infusion-related rashes. Maya, which of the alkylating agents are used in ovarian cancer?
In our previous cytotoxic chemo episode, we discussed ifosfamide and trabectedin, which are both used primarily for uterine sarcomas. Ifosfamide can rarely be seen used in ovarian and cervical cancer. Remember that alkylating agents have positive charged alkyl groups, which bind to negatively charged sites on DNA and form DNA adducts. This results in single or double-stranded DNA breaks and/or crosslinks. Cyclophosphamide is another alkylating agent used in ovarian cancer, specifically in recurrent epithelial ovarian cancers and as part of some combination regimens for ovarian germ cell tumors. It's part of the Emico regimen for high-risk GTD. Cyclophosphamide is interesting in that it requires multi-step metabolic activation before it has anti-tumor activity. The classic toxicity associated with cyclophosphamide is hemorrhagic cystitis. This is common with high-dose therapy. Mesna should be given with this agent as a bladder protectant, and if patients develop hemorrhagic cystitis, aggressive IV hydration can be part of the treatment. Other common toxicities include alopecia, nausea and vomiting, and myelosuppression. Dosing for Mesna is generally 60% of the prescribed dose of ifosfamide or cyclophosphamide for doses over 1 gram. Myelosuppression tends to occur 8 to 14 days after administration and tends to be brief. Patients can also get other dermatologic side effects such as skin pigmentation changes, nail changes, facial flushing, and dermatitis. Rarely, patients can develop secondary leukemias. Sydney, are there new anti-tumor antibiotics to discuss?
Yes. In our uterine cytotoxic episode, we reviewed doxorubicin and Doxil, which are used both in uterine cancers as well as in recurrent epithelial ovarian cancer. Bleomycin is another anti-tumor antibiotic, which is part of the BEP regimen for ovarian germ cell tumors. Bleomycin is produced from the fungus Streptomyces verticillus. It interacts with the copper or iron cofactors to form superoxide anions and hydroxyl radicals, producing single-strand DNA breaks. Bleomycin is cell-specific for the G2 phase. The serious dose-limiting toxicity associated with bleomycin is pulmonary toxicity, which can take the form of interstitial pneumonitis and pulmonary fibrosis. This can be severe and is related to the total cumulative dose received by the patient. There is a greater risk with a total lifetime dose of greater than 500 units. Interestingly, exposure to high oxygen concentrations also increases pulmonary toxicity. Smoking, including vaping, can be very harmful to these patients. In patients with a significant smoking history or active use, cessation should be strongly recommended, and PFT should be obtained with every cycle. The protocol can vary from institution to institution, but one option is if the DLCO is less than 70% or the patient is unwilling to quit, bleomycin is held and sometimes an additional cycle of EP is given. Hyperpigmentation is another common side effect. Patients can also experience mild myelosuppression, nausea and vomiting, anorexia, and dermatologic changes such as pruritus, hyperkeratosis, alopecia, rash, skin peeling, and mucositis. A more immediate side effect can be fever and chills, which shows up within 4 to 10 hours of administration and lasts for up to 12 hours. Maya, do you want to tell us about our plant-derived agents?
Of course, my favorite group. Remember that other agents in this group discussed in uterine cytotoxic include paclitaxel, Abraxane, docetaxel, and topotecan, which can all be used in ovarian cancer as well as in uterine cancer. Etoposide, like bleomycin, is used in the treatment of ovarian germ cell tumors and in advanced epithelial ovarian cancer. It's also a part of Emico for GTD and is sometimes used in uterine sarcomas. It can be administered in either IV or PO formulation. Etoposide is a glycosidic derivative of podophyllitoxin, which is produced by the mandrake plant. Etoposide interferes with the function of topoisomerase II, creating single and double-stranded DNA breaks and causing DNA supercoiling. Rare but serious side effects include a risk for anaphylactoid reactions and risk of secondary leukemia. The leukemia risk increases markedly if above a dose of 2 grams per meter squared. More common side effects include myelosuppression with leukopenia, with nadirs at 7 to 14 days. Nausea, vomiting, mucositis, anorexia, alopecia, and peripheral neuropathy are also common side effects. In our uterine episode, we briefly discussed the vinca alkaloids, which inhibit microtubular polymerization, leading to mitotic arrest, very similar to our favorite class in GYN of taxanes. Vinblastine is a vinca alkaloid which can be used in germ cell tumors, and vinorelbine can be used in recurrent ovarian and cervical cancer. Vincristine is another vinca alkaloid, which is the C in Emico for high-risk GTD. With the vinca alkaloids, dose-limiting toxicities can include leukopenia and hypersensitivity reactions. Patients can get severe obstipation due to neuropathic ileus and abdominal cramps with vinblastine. These agents can cause skin necrosis and sloughing if they extravasate during infusion, and vinblastine can also cause rash and photosensitivity. Patients can get neurologic toxicity, including peripheral neuropathy, autonomic neuropathy, which can result in constipation, headaches, as well as rare seizures and rare cortical blindness. Other side effects include alopecia, mild AST and ALT elevation, joint pain, and SIADH.
That's all we have for you today. Between the agents covered today and those discussed in our uterine cytotoxics episode, we've covered the key agents used in the treatment of ovarian cancer. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows.
This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Jen McDonald, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.